Hey, Chad.
Evening, everybody.
Hey, everybody.
Steve?
Hi, guys.
Steve,
Diego.
I reach out to everyone about coordinating for tonight. So I asked Diego if he wouldn't mind facilitating. So
Sounds great.
Hey, Steve, did you listen to that voicemail I left you
When did you call?
10 minutes ago?
No, I haven't. No, is it important that I do that?
I would prefer for you to listen to it. Yeah,
Okay, all right.
thanks.
I feel like I haven't seen you live and in person in like 100 years. Yeah, like you're live and in person, but you're alive. I'll give you that. No, Phil, sorry. I see you all the time, Diego. That's old news.
Yeah, I try and keep my ugly mug off the television screen as much as possible.
I understand that sentiment. I do the same.
Thanks, Renee.
we still have folks coming in. There are a couple more that we're waiting on. So if you wouldn't mind just waiting 2 more minutes to get started, if that's okay with you, Diego.
No problem.
Thank you.
Chad, how's everything going down the southern tier?
It's as good as you could hope.
Gotcha.
There's good days and bad days. Abject terror.
Yeah.
Jane, I'm going to make you co-host so we can both keep an eye on the waiting room if you don't mind. Thanks. Christy, I think we might ask you to go first. We did have Danielle on the agenda, but I know she's traveling. So if you wouldn't mind going first when we're ready to get started. Thank you. Never mind, Danielle just popped in.
See, that's how it works, right?
Best laid plans.
Exactly.
Sorry, I'm here.
No
Hi.
problem. Hi, Danielle.
Hey, Danielle.
Hey, Daniel.
Hello.
We'll give it 1 more minute, Renee.
Hey, Danielle, how are you doing?
If you wouldn't mind.
Good, how are you?
Good, good. Long time no see.
I know, it's nice to see your face again.
I know. You too.
Yeah, noticed she didn't say that about you.
I was hurt, you know.
Yeah, that was noticeable.
Yeah, I'm sure I'll get over it one day.
One day. Just don't pick on me like you do Jenny.
Right.
Oh, I can't promise that at all.
Well, there are 5 more individuals who said they would be joining us this evening who are committee members, but you want to get started, Diego? I understand.
Okay, absolutely. Well, welcome everybody to the Adult Primary Care Advisory Committee meeting. We have a pretty full agenda tonight, and we're starting with care management and ending with some training opportunities. I also have a call out that I'd like to talk at the end about how this committee can further everybody's potential needs going in the future, and how we best can allocate our resources. So at the end, I'll probably talk about that a little bit more for our individual practices. So let's get started. Danielle Calder, if you'd like to start with the care management job description, that'd be great.
Sure. Thanks, Diego.
Yep.
I'm going to share my screen. 1 second. Okay, can you see my actual slides?
Looks good. Yeah, we can see him.
I'm only on one screen today, so it's a little different. All right. Oh no, hang on. Okay, that one screen threw me. I need my notes.
I'll run your presentation for you, if that makes it easier for you, Danielle.
Sure. Sorry, I didn't think about that, Renee.
It's okay, no problem.
I need to do multiple monitors.
No problem. If you want to start introducing your topic, I'm just gonna got these little errors that always come up when I open PowerPoint. So go ahead.
Sorry, I'm trying to get my screen. Okay, so I just wanted to take a few minutes today. Thank you for the time. Just to kind of share with you some updates that we have. Specifically this summer, we've been developing what we're calling our functional job description. And so the intention of this document was really to establish some clarity for the care managers, as well as the practices on the care manager role as we reemerge from the COVID pandemic. Additionally, I was looking to provide us a more standardized process for onboarding new care managers to the team. Many practices have already received this document, but I did want to take a moment to share with you the process that we went through, as well as draw attention to some notable adjustments that we made, and then what we still consider some of our shared responsibilities. So I know the font is small on this next slide, but what you see here is the functional job description at a high level. At a quick glance, you can see that our role continues to remain largely unchanged in function. The sections that you see highlighted on this document really account for only about 10%. And those are the areas that we've spent time further clarifying. So tonight, high level, I just wanted to give you an overview of those specific areas that we wanted to provide additional guidance for our role. So the next slide. Yep, next slide.
Come on, sorry.
It's okay. So what you'll see when she flips is that we're still sticking with those 3 foci of care management, transitions care management, complex care management, and population health. Specifically on transitions, we've really aligned and adapted our work for possible discharges to AHP's 5 contact program. So just as a reminder, that's the readmission reduction program with defined engagement points for patients with those within the 30 days post-discharge. I'm hoping to decrease their experience of unnecessary readmissions. Additionally, care managers are prioritizing those high-risk discharges and then collaborating with your practice teams to make sure that those lower risk patients in your practice are still being cared for. Care managers are connecting with patients with more community-based organizations and resources. If you're not familiar, we do have a partnership with Lifespan to serve our patients, which the care managers have come to really rely on that partnership to serve patients in a way that we often have not been able to. And lastly, care managers are still coordinating and supporting care for those patients that are at home but need support on transitioning to a higher level of care. In complex care management, again, you see that we're really targeting those highest risk patients, those patients that are having difficulty managing their multiple chronic conditions or experiencing social determinants of health, and collaborating with your practice teams to care for the remainder of your panel. We continue to provide evidence-based protocols that are protocol-driven disease management support based on our care management protocols that we have. And we still continue to consult and engage our AHP clinical teams, so pharmacy, social work, and the behavioral health integration team as well. And additionally, we are looking to collaborate more closely with you in caring for your patients in crisis management. This is a little bit of a change from our historical thought process in our role. And so I just wanted to highlight that. In the past, our care managers received some in-depth training to work with and support patients with depression or anxiety that may have been in crisis. And what we're finding is that even with that training, we're still not adequately equipped to really manage or lead that care for the patient. And so we're really looking to partner with you in a more meaningful way to accomplish that. And lastly, in population health, we are focusing more on our care management sensitive quality measures, and then supporting the integration of data coordination, as well as partnering with them to support the closure of those gaps. And then generally speaking, this slide, our shared responsibilities are consistent with what we currently experience and expect. We expect that the care managers attend and participate in team meetings, both at AHP and in your practice. They're expected to integrate AHP initiatives into their clinical work and support your teams in doing so as well. And since the pandemic, we have limited the frequency of our team or our care managers completing home visits. And due to our increased partnership with community-based organizations like Lifespan, we are going to continue to limit home visits for this time for care managers. And as I mentioned before, your partnership and collaboration in caring for all of your patients is really important moving forward. And just more specifically for the care manager, they have and will continue to participate and lead discussions around difficult cases that they experience with our teams. And I'm hopeful that they're doing the same thing with you. So when they have a difficult case, they are discussing and debriefing on that case with you directly. I am seeing my slides. We also expect that the care manager participate in project rollouts and support you and your practice teams accordingly. And lastly, the care managers will continue to act as an advocate and a liaison for your practice as well as AHP. And this is a bullet point or an area that the care managers value really. They kind of hold close to their vest on. It's really important to them that they represent AHP in your practice, but also they share about your practices and what might work or might not when we're discussing new initiatives. And so this was an important area for them as well. So that's all I have for you. I just wanted to thank you for your continued partnership with care management. Your partnership and dedication and support to our care managers is really vital and is what makes us successful.
Thank you, Danielle.
Yeah.
Does anybody have any questions for Danielle? Danielle, quick question for you. Do you feel that you have the adequate resources to kind of be able to, reach out to all practices at this time, or do you think this is a growing need?
For the functional job description, or what are you referring to?
For care management, in order to achieve the functional description.
Yeah, so currently we're embedded. The practices that we're embedded in, I think we're fine to continue to support as we have been. The intention wasn't to limit care management or change how it is, just to give a little bit more clarity. As you know, our program, just like everything, is always evolving and developing, hopefully for the better. So this was just one way to communicate some of those changes out.
Yeah. I think the model that we've changed to, at least in part of my office, has been helpful because I think we've been able to partner in a very collaborative way. So I think that's very helpful. But it's a question of, as that grows, where are your resources going to be needed, right? So that's sort of the question where I was leading to.
Yeah.
I-
That's what
I have a
part.
question.
Mhm.
How, we have a wonderful care manager who's new, and he's doing a great job. I'm wondering what the interface is with you, because I don't hear from him about his connection with AHP. How often are there meetings with the care managers? You said there's training, and if I understood, are there periodic meetings?
Yes, for my team, I don't know what practice you're at. I apologize.
Sorry, yeah. Southwedge, it's Gamma, Geriatrics and Medicine Associate, Gamma.
So for our team, we are serving the community-based care managers. And so you have a newer care manager. I'm not sure if we have taken the opportunity to loop him in to some of our team meetings, but we can definitely talk about that. But yes, my team meets weekly. We have a small team meeting weekly and then a larger team meeting twice a month.
Okay, thanks.
Yeah.
Elisa, would you be willing to just talk about your role in the CMO and how that,
Thank you.
Lisa having sound issues or, okay.
While Elisa's trying to fix
There
her
we go.
sound. Oh,
Go ahead, Steve, please.
I just, Danielle, could you just, it looked a little bit to me like you mentioned that at least in the community practices, your team is doing some depression care management. Is that actually the case, or is it not? You talked about crisis management for anxiety and depression. Is that officially depression care management or not really?
No, not at all. And that's kind of the point, is that our model has slightly shifted. Originally, I think we were trying to get there to bridge the gap in primary care a little bit more, but we can't do that, nor are we trained and equipped. So we have the collaborative care model. I see George on here. So we have the collaborative care model that is another strategy, but we are really looking to partner and use some of those resources as well as your team, but not own them.
Thanks.
Yeah.
So just going back a click, my apologies for a difficulty coming off of mute. I did want to go back to Diego's question, and then Dr. Markakis, I did want to bring up Gamma. So for those of you who I have not met, my name is Elisa Stetzer, and I serve as AHP and the CMO, the Care Management Organization Senior Director. And one of the things that I certainly work closely with in our model of care management in the community, also in the PCN, where we're supporting the work there is do we have the resources? And actually, one of the things that I think is really important to call out is that your practice, Diego, is in a bit of transition, and the collaborative model that you have been able to transition to, we're not entirely sure how long that will continue to be needed in sort of a centralized function. That said, my guess is that we'll see other practices with transitions, whether they're for the same reasons or not. But we've just hired an additional care manager to support a centralized model, which when we have that written down and fleshed out, we would like to bring back to this audience as well to talk about the centralized model. So that's one way to ensure that practices like yourselves and other practices that have historically had care management, but we've not been able to sustain them with an embedded model, can continue to get resources. So I hope that addresses your question in some ways about resources. Dr. Markakis, nice to see you. I'm familiar with Kyle Silvestri at your practice and my work across the institution, and have supported him and the nurse practitioner, Kristen Susu, in their workflows with our informaticist, Michelle Black. At this time, he is not working under our community or primary care network workflows. Those are practice determined. And so, happy to continue to support the development of his work there. My understanding is it's almost entirely a transitions care management model at this time.
Yeah, thank you.
You're welcome. Other questions?
No, okay. Danielle, thank you very much. Appreciate it. And now we'll move on to population health with Christy.
All right, thank you. So I'm gonna hide the chat and share my screen. And I just got a couple of slides to share with you. So tonight I'm here to talk to you about our population health management platform, our current state and our future state. So we can do this in a couple of slides and want to share with you what's going on at AHP. So as many of you know, or may not know, our current population health management system is Arcadia. We've used it at AHP since December 2014. That's over 7 years. So it's been cornerstone for our data aggregation, quality performance reporting, our patient management, care management, and we've leveraged it significantly as a data warehouse for a lot of our reporting and our analytics work. We've been having some systemic issues with some of you are very well familiar with your partners in our journey to try to solve some of the issues here. I call them systemic issues because they've been really long-term. We've been working on some of these things for multiple years, and we have been not making a lot of progress. We make a little bit of progress and then a lot to step back, or we get just no progress at all. Some of the ones that are really important are connector problems. And this is kind of the techie side of things, but it really all starts here. This is how the data flows from your EMR systems into our system. And we have a lot of times when they're on or they're off, or there's been a change and now something's broken. And an example of the severity of these problems is last year we did not receive Epic data, which is a large portion of our patient population in the network, for 8 months. It took 8 months to identify the problem and fix it. Other issues are they're very slow to implement new practices or make connector changes, like when we changed the Epic expansion to the southern tier. Data needs to come from a different system for those expanded sites. We get late delivery of our quality measures. So we've been running until we got our upgrade this fall. We've been running on 2019 version of our quality measures. And we also could not receive some of the new ones that had been implemented in 2020 and 2021 because they weren't built for our version. We have now forever, and now even more so since the upgrade, incorrect measure performance. The latest and greatest is we lost 50,000 colorectal cancer screening gap closures in our reporting. And we know we have the data, we know we're high performing in that area. It's just that something broke in the back end system that isn't mapping correctly. So to share, this really means we have poor system and data quality processes in this Arcadia platform. They're very slow to support and provide resolution to our issues. They miss and they delay timelines. They miss deadlines, almost 100% rate for right now. The reason this is really a problem, if that isn't convincing enough, is the substantial business impact to the practices and AHP. We are unable to trust the accuracy of the system for pre-visit planning, for quality reporting, for the general reporting we need to do to identify and monitor different initiatives with our analytics. We're unable to identify quality performance issues in time earlier in the year in time to have to make impact and to improve performance in that year. We can't turn things on in October and have missed the opportunities for patient outreach and gap closures earlier in the year. AHP and practice staff are spending an excessive amount of hours, far too many, validating this system, working around issues, creating workarounds, and ultimately manually overriding the reports. Imagine what we could do if we weren't spending time doing this, both in the practice and at AHP. So looking forward, what are we going to do about it? So this has been a long-standing problem, and it's been getting worse. And so we've had some very serious conversations amongst us at AHP and also at these advisory committee meetings. We all agree we need to have a strong partner to support us with the services and tools that we need to manage this work. So we have done a lot of work this year on an RFP project where we decided to go out and look at the market and find out what our other options are. What are other people doing? What are the other systems that are available to us? And to determine whether or not it's time to make a decision on whether we stay with Arcadia or we can move forward into our future with another platform. So we're into October and we've already gone out with an RFP. We received 9 responses from different vendors. We narrowed that down into 4 vendors that we wanted to see a demo of their services. And we've completed those demos. We're doing a couple of follow-up meetings with them just to get more details, and then we'll narrow it down to 1 or 2 finalists. We're also having a meeting with Arcadia. Arcadia is our incumbent. They're well aware of the issues that we have and our concerns, and they are a respondent to our RFP as well. But because they've been working with us for so long, we don't need a demo of their system. We need to have another kind of a conversation with them and talk about how they're going to earn our trust back. How can we stabilize this environment if we decide to move forward with them? So all of that will then lead into some more deep dive discovery sessions with the finalists and with Arcadia. We're going to be looking at references. We are going to be making sure that if we make a decision to move off of Arcadia, we're not moving into another set of problems with a different vendor. We want to be sure that we are moving in a direction that's going to support all the work we need to do for you and this network going forward into our future. And we're going to present a recommendation to the board at the end of January. So, any questions?
Well, I think that it looks like some potential changes might be in the future, maybe, or maybe not. If not through Arcadia, through someone new. And I think the questions will come as we get closer to the picking of the new or revitalized management system.
Decide to change from Arcadia to one of the other vendors, how long do you anticipate the transition is going to take?
Well, it's really going to depend upon the vendor that we choose. There are current estimates anywhere from a couple of months to 6 months. And it's just given a high level understanding from them and between us on what we're looking for. It will absolutely be an iterative and a phased project. We will be focusing on the highest value, most important things we need to do, like being able to get the data connections in place and start feeding information for the quality reporting for our contracts and for the things that you need to have visibility into. But it really is going to come down to which vendor it is, and that's part of the decision making too. How long are they going to take to bring us on line? If there's one that can do it a lot faster and they both look pretty good functionality wise, we're going to want to make the transition as fast as possible.
I'd just interject a comment here too for the committee. Certainly understand that we don't undertake this lightly. We realize that this is a big deal. This is such a big part of our work with the practices. And we know that there'd be some short-term disruption to doing this, but I think as Christy has laid out well, for the last couple of years anyways, it has really been an unreliable system that has undermined our ability to manage our population patients as we want to. And so I think we have no choice, unfortunately, other than to take a serious look at this. And there is no preordained conclusion here. We're gonna talk to Arcadia as well as the others, but I think we have to do this. And in going through the process, it's really also shown us, what other capabilities are out there that we think could advance our mission, and we need to take that under serious consideration, and we will.
So I'm a little surprised to hear that Arcadia is still in the running, given the amount of time that you've been working with them, trying to solve problems and not getting a solution.
They're falling behind in the race. Let's put it that way.
Right. And right. That's fine. But I would just state that opinion.
Yep, I hear you and I agree. But we do need to make sure that we're not missing something that's going to be changing there. There is a lot of work, and it's a huge investment of time and money to make a switch like this. So we're covering all bases and making a really informed decision.
Good. Well, thank you very much, Christy. Appreciate the update. More to come, apparently. Dr. Nasra, you'll give us a collaborative care update, please.
Yes. Thank you, Diego. Good evening, everybody. I only have just a few slides. Some of you may remember that Elizabeth Sharp and I actually presented on the collaborative care model. Just give me 1 second, I apologize. Back in July. And the purpose of the presentation today is to give you, kind of remind you of the project, but also give you an update on where we are, and remind practices that we are still in the process of asking for whoever is interested in learning more to contact us. So without going into too much here, you remember that the collaborative care model is this model of behavioral health integration where we embed a dedicated behavioral health clinician into the practice to work with the patient, to collaborate with the primary care provider, and to receive weekly consultation and support from a psychiatric provider. It could be a psychiatrist or a psychiatric NP. And with that team approach, taking a population health kind of approach to care, entering data into a registry, making sure that patients who are contacted are receiving interventions, but also people who are dropping out of care are engaged, and they are also, there's an effort also to re-engage with them. So that's the population health approach where nobody's falling through the cracks, and following up with measures, PHQ-9, G87, promise scores, whatever we choose to implement, and following up to make sure that there is actually an improvement in the symptoms and care of the patients. That's the collaborative care model. And Steve's question earlier really is an important one. How does this differ from the embedded care manager is important. This is a dedicated behavioral health resource where the, although we call them behavioral health care managers, they are only addressing the behavioral health needs of the patient specifically through behavior activation, problem-solving therapy, motivational interviewing, and they work on a continuum with the embedded RN care manager in the practice, as well as if the practice has an embedded social worker, therapist, or someone that you're used to referring to in the community, that does not duplicate service, that actually falls on that continuum of care for behavioral health. Obviously, you know that addressing the behavioral health needs of our patients is not going to, depending on the levels of care. So to reduce the initial cost of embedding a resource like this, and also to reduce the ongoing cost of having to continue to pay for a clinician in the practice and a psychiatrist consultant, we decided to partner with Concert Health, a company that offers specifically that service. That's all they do. They offer collaborative care model nationwide to different health systems and practices. We have been meeting with different practices, both from the primary care network side and the AHP community side. That's what we've been doing over the last several months since July. We have formed an implementation task force. We meet regularly with Concert Health. With the practices that are interested, we explain the model in more detail. We introduce the team at Concert Health. They get to ask questions about the model clinically, about the implementation, the financials. And then what we found out is that different practices are in a different place, right? So some of them are ready to start negotiating a contract. Some of them are more interested in waiting a little bit longer before they have the right team in place to implement this model. On the primary care network side, we are targeting 3 practices at this point, potentially up to 24 providers, and the conversation is ongoing around that. And the AHP community side, we outreach to 8 practices, including some of the hospital employed practices in the community. And those 8 practices, we are continuing to meet with them and answer questions and see where they are with their readiness for implementation. I mentioned we are actively, I'm trying to remove from my screen here. So each practice has its unique challenges. I mentioned that, and that's how it should be, right? So we want to meet the practice where they are. We're not asking anyone to sign on the dotted line after the first meeting with us. So we can be patient, wait. This is a project long term. We don't expect anyone to make up their mind right away. And Concert Health is with us on that. So we want to have the opportunity to meet with as many practices as possible, introduce the project, and then support them, when they are ready to move forward. So that's basically what I wanted to mention, and to remind you that it's not too late. This is not going to go away in January of 23 or July of 23 or even in 24. This is an ongoing project, kind of rolling in kind of admission, if you want. So anytime you or someone from your practice is interested to learn more, we are happy to meet with you, myself and Elizabeth, or anybody else from our implementation team. Any questions?
George, Steve, as you know, I'm very excited about this, and I think on our end, it's just a matter of a big, slow bureaucracy trying to get contracts in place and everything. That's my understanding. Can you just, so in the group, with the groups you've met with so far, you mentioned people will get there at different times and talked about readiness. I guess one of the advantages in my mind of this is that it's essentially telehealth. It's right. I mean, I know that they may sometimes have someone in the practice, but it's largely someone outside of the practice. What are you hearing are there particular concerns that practices are raising about ability to implement this? I'm just curious what the perceived barriers are to it, because it seems like the obvious solution to our behavioral health problem. So, or maybe not obvious, but the only one that's becoming very clear to me. So what are the barriers?
Yeah, that's a great question. So the barriers that we are hearing is different, whether it is, a smaller practice, a large group of practices, but mostly the barriers are practical implementation. Are we ready right now? What are other competing priorities right now? There's a practice, for example, that has 2 out of some of their billing people have left the practice, and they said, we want to do this. We're trying to hire more billing folks, and we will contact you again in January. Some of them want to understand a little bit better the risk involved, the business model itself. So there's back and forth around, explain to me, what does this mean? When do we get an invoice, and what if we did not meet the threshold? Are we at risk? How much support does Concert Health provide us if we are struggling with the workflow? Do we need to credential those providers into our system? Wait a minute, we need to take this to our board and see if we need to actually formally credential everyone on your staff or not. So practical implementation questions. None of the people or practices that we met with have been saying to us, we don't think this is valuable or we're not interested. It's those practical questions. And I'm happy to say that Concert Health so far has been very flexible, even to the point where they are saying, if you have concerns about the boilerplate contract that we're offering you, make the changes that you want, send it our way, and we will have a conversation about that.
Thanks, George.
And I am happy to say, Steve, that both John Clark and Rob Fortuna have been really at every meeting responsive. I'm really excited about this collaboration.
Any other questions for Dr. Nasra? Dr. Nasra, thank you very much for that update. Appreciate that going forward. And now your honor roll Chad Teeters will be talking to us about the reward plan coming our way.
That's right. So some of you have already heard this. We talked about it a little bit at Clinical Grand Rounds the other night. We've talked about it at the Wednesday, I think, COVID call previously. But apropos and following on the back of what Christy presented as some of our Arcadia issues for this year and tracking our performance to the metrics, we spent a lot of time looking at both our performance and our ability to hold practices and providers to account for their performance this year, and come to the conclusion, based on everything that you've already heard, that neither do we have confidence in the data that we are receiving, nor do we feel it would be fair to our providers to hold them accountable, as we have in years past, to performance thresholds for points achieved on the metric grid. For that reason, as we look to paying out the rewards for quality metric performance, we've decided that for the 2022 performance year, that we will not hold practices or providers accountable to total points achieved as we have in years past. And we will divide the total gain share earned equitably amongst all providers, with the only divisor being For practices that have less, or providers who have less than 500 patients attributed to the contracts, they will have a lower tier that they will cap out at, if you will, in their reward. And practices or providers with over 500 patients will receive the maximum amount. So essentially there'll be A and B tier, tiered only by size of the attributed population. Obviously, this is a big decision. You know, we take our performance very seriously. Thankfully, you know, we have achieved enough points on our contracts to maximize any potential gain share. So there was no need to falsely hold providers to account that, truthfully, I don't even think we could look you guys in the eyes and say that we had a high degree of comfort that the data that we have is correct right now because of the issues we're having with Arcadia. So our intention would be for 2023 to go back to our performance thresholds as we have in years past, with the hope and understanding that we anticipate being able to report both for pre-visit planning, but also for actual performance thresholds, demonstrate the actual performance by practice. But for 2022, it will basically be a little bit more egalitarian, where payment will be only divided by attribution size and not by points achieved on HEDIS performance. So that's a kind of quick and dirty. I don't know if folks have questions about that. I think you've heard now fairly in depth as to why we came to this, but it seemed the only fair way to really do this. Okay.
Thank you very much,
Thank
Dr.
you.
Peters. And now we pass the baton off to Renee Sutton, who will carry us to the end.
Thank you. I'm glad with our organization of this agenda that I'm following up to Chad's information that we're going to, you know, by and large, be holding providers harmless for the 2022 PCP reward plan. Because what I want to talk to you about is the provider engagement report, and we have been talking to providers about the provider engagement report very much in the context of that PCP reward plan, because it is a reflection of a provider's performance towards incentive. And, you know, one thing that I has certainly emerged are a lot of questions of like, oh, we heard about being held harmless for 2022, so I guess I don't have to look at the PER, right? No, that is not the case. We still are moving forward to implement the PER. The PER is going to be your tool under the 2023 PCP reward plan, which we hope as much as possible to keep as aligned with 2022. Because you didn't have any opportunity in 22 to work on anything. So for the 2023 performance year and the reward plan, we're moving forward to continue to implement providers to the PER. There is a guest account process, and my colleague and provider relations, Cherie Turpin, is the face of that guest account process. So as users in your practice sign up for the PER, they'll be getting lots of emails from Cherie to get that guest account process finalized and give you access. We've been doing some large group trainings on the PER, and the recordings of those can be found on our YouTube channel. We are going to schedule a couple more. The final large group meeting that was on the calendar is on Monday, but we have a couple more in the hopper to throw up on the calendar, and we'll make folks aware of when those are. So just want to make sure that I'm leaving you with the message that just because 22 reward plan is going to be paid out on an equal basis doesn't mean that we're slowing down in any way on the PER implementation. Still moving forward, still going to be an important tool for you to manage your performance in 23. We will continue to work with this group and make you aware of all of our progress in PER implementation. And certainly hope at some point when some of you around the table have been implemented and are using the tool, would love for this to be a forum where you share about your experience doing that. Please let me know if you have any questions about where you stand in the PER. And I should say as well, it is also much in the way that Arcadia was not anything that any provider logged into every day. I see the PER being the same type of tool, and in many practice settings where you have a quality infrastructure, you have someone in charge of quality whose job it is to watch the performance. that might be the right choice to implement the PER 2 in your practice. And we're working with practices to identify the right people. Any provider that wants access to the PER can have access to the PER, but also just want to make you aware that we're trying to make sure that we have customized implementations across different practice settings to make sure we're doing what works best for how you work. So lots more to come on the PER. I'll stop there and take a breath, see if anyone has any questions. No? Okay. Well, then I will move to my final agenda topic and final agenda topic for the evening, which is just to make folks aware of, you'll be getting an invitation soon to a training opportunity that actually participating in it will satisfy one element of the reward plan for 23, and that is a long-acting reversible contraception counseling and access training. So this invite is going to be going out tomorrow. We are offering 2 trainings that will both have identical content. And one's going to be Thursday, November 17th at 5:30. The other is going to be Wednesday, December 7th. Don't feel like you need to scribble this down furiously. You'll be getting the invite tomorrow. And all primary care, adult and pediatric, family medicine, internal medicine. We see there's an opportunity really across the board here. All primary care and OBGYN providers are going to be invited to attend this session, and it's entitled Increasing Access to LARC for Your Adolescent and Adult Patients Through Evidence-Based Counseling and Practices. And it's going to be presented by Dr. Rachel Phelps, who is a family planning expert and a physician with Planned Parenthood. And it's a 75-minute lecture and Q&A, and it's going to have the most up-to-date information on evidence-based, patient-centered reproductive health counseling, available resources, and strategies for removing barriers to contraception access, with the focus being on long-acting reversible contraception. So want to make folks aware of this opportunity. There is no cost to providers. And as I mentioned, for individual providers, it will satisfy a cost savings component under the PCP reward plan. If I said citizenship earlier, which I think I may have, I apologize. It's not citizenship. This is under the a cost performance initiative under the PCP reward plan. So I'm sorry. I noticed Christy looking askance at me, and I'm like, what did I say? And then it's mostly because I talk about citizenship. So my apologies. So that invitation will be going out tomorrow, and we'll also include it with a follow-up communication that we'll be sending to members of the PCP Advisory Committee, those of you that are on the call today, and those of you who missed this meeting. We want to get back in that cadence of providing you good follow-up information from these meetings. So you have a one-stop shop communication, something that you easily can reference, something you can easily share with your practice partners. That is part of what we're hoping that your participation in PCP Advisory accomplishes, is that you bring back what you've heard here to share with the people in your practice. My colleague Jana Darlington on this call did a fabulous job putting together a version of the communication I'm describing for the Pediatric Advisory Committee, and we're going to implement it here in the adult side. So tomorrow or Monday, you'll be getting a follow-up email that'll just contain, good, small, easy bites of the information that we delivered tonight. That hopefully you'll find easy to take in, understand what your own responsibility is relative to the information, and have an easy tool again to share with other members of your practice. So it started out just talking about LARC, ended with telling you about a follow-up communication, but Diego, I promise that's it. That's all I've got. So thank you for listening.
That's good. That's good. No, I think all those things to kind of understand the PER and who benefits from the PER and who has what pieces of that puzzle, since it's a big dashboard that we have in place, is going to be important. And I think that the education of all members and how it affects both the PCN network as well as the community practice is going to be important. And there's probably a lot more work to come between now and then, but it's an important opportunity. So I think tomorrow's communication is going to be important for everybody to pay attention to, and then see how best it fits into their practice. So any further questions for Renee? No. So it looks like we're going to end early. I do want to bring up what I was talking about at the beginning of this meeting. I wanted to bring a moment to ask this committee and all its members and to take back to their practices and to maybe practices that are not represented here, to start thinking and offering suggestions on topics that we should be addressing at this meeting. So I feel that there are many topics, both the PCN network and the private physicians probably have tucked away in our brains that we, affect on a day-to-day basis, affects how we practice, medicine. And I think that it's a moment to bring some of these ideas back to our committee so that we can partner better in addressing these needs. In part for AHP to understand what resources it's going to need to address those issues, because I think AHP is going to need more resources to address some of those issues as we unfold them, as we find them, because I think we need to find these particular topics. And we also need to understand from the community what those potential pitfalls are that inhibit us delivering the patient-centric care that we all want to give to our patients, right? We talk about metrics, we talk about numbers, we talk about dollars, but at the bottom part, this is all about the patient, right? And we want to deliver the best care of the patient we possibly can. So are there access issues that we really need to address? Not really complain about it, but how do we address those issues? How do we get to the core of those issues, right? So I think AHP and this committee, in part because we represent both, the primary care network as well as, private physicians, how do we advocate and how do we make changes for access to actually occur, right? And I think we start having a voice for that. I think there must be procedural issues both with insurance companies and or, Medicare and or MIPS and or any sort of, reporting system that is tied to different programs that maybe some of the practices have a problem, implementing or have a problem being able to report out. And this committee, again, could be a stepping stone for those things to occur. Are there ordering issues, right? Are there, vaccines, things like that, that we can potentially, again, find a solution for practices to be able to, again, deliver care and deliver these needs to our patients. Billing issues, right? So if there's billing issues that occur that we need to do. So I would like everyone to kind of go back to their practice and maybe even have in their next practice meeting an idea of what are the topics that are important to address and how can this committee address those topics both, in the community and as HP as an organization, because I think we need to have a bigger voice in all of our practices, both the PCN and the primary, the private practices. So I'm sure that sending an email to Steve or Renee or Chad would be a starting point to start developing this list and maybe start developing action plans to kind of deal with some of these topics.
Diego, can I just quickly say a couple of things that would be great to kind of have on that list? One is we're trying to bypass the emergency room whenever we can. And one of the things that's really frustrating and gets in the way is if we think that there's a stat imaging test that needs to be done, to rule out acute diverticulitis or to rule out something else. We can't do it. We end up sending people into the emergency room just to get a study. In this crisis time, when we're trying to not send people in, is there any way to say this is COVID, crisis mode? Please just suspend all prior authorizations, because that would really help us to do our job better, but also to relieve some of the stress on emergency rooms with unnecessary referrals that we might be able to handle if we had the ability to have, stat ordering that we could just immediately schedule. So that's a top plea.
Right. I would say, Valerie, to that, so I think there are certain diagnoses like appendicitis and diverticulitis with abscess that you can actually bypass the prior auth with a SAT organization. Sometimes takes a phone call to the provider, but certainly something we can look into. The other problem is the timing of that, right? So if someone calls you at 9 a.m. in the morning with that, much easier to get them in that day than if they call you 4 p.m. on Friday, right? But I agree with you that even at 4 p.m. on Friday, we should be able to deliver the same care. So that's a great point, and that's something that we could certainly look into. That's exactly the kind of things I was talking about, right?
Yeah. And just one more thing,
that we are on the hook for the expense budget under our value-based contracts, right? I mean, we are at risk, so we have a way to check our behavior. So, trust us, suspend the prior authorizations.
Right.
It's not like we're not on the hook for the cost. We are.
Yeah.
Sorry, I didn't
just
interrupt you.
Sorry. And just one more thing then, is I don't know if there's any way, I know that we have all of these models for, are you hearing me okay? I just didn't know. Okay.
Yes.
Yep. Okay. We have these models saying, collaborative care for psychiatry. What we need social workers to help us with patients in crisis. The other reason people end up in the emergency room is we have a crisis situation. Our care managers are not in a position to be able to help, especially if there's an intense mental health component to it. In the olden days, we used to have social workers that could just jump right in and help us with all the different resources that were needed, again, to keep people out of the emergency room. Again, to say this, if we could have X number of dollars to have social workers that have some acute crisis behavioral counseling ability, and they would have the resources to get things together. We've got people who have got hypertensive emergencies that if we had a social worker actually getting the right resources, then we could manage them out of the hospital, but we can't. So they end up going in. And so again, I would just say if we could put it under the heading of, are these categories that have just
I think those were two very good examples, Valerie. And that's, those are both very good examples of, delivering the goal. And I think that both of those examples clearly, establish that need. And we have to look into options like that. So I think those were excellent points. Practices and really try to develop our committee, and Steve and I are committed to really trying to deliver the best care for patients through all of us. And if we can do anything to help your practices, I think that's what's going to be helpful. And we just need to make sure we have the right resources to do so. And with that, if there's no further questions, it looks like we'll be finishing slightly early today, which is good. And we can all go to our normal lives, and we'll reconvene in a couple months. Good night, everybody.
Thanks, everybody.
Thank you.
Thank you.
Night.